This afternoon, we have with us 4 speakers. We have Kelly Naylor from UNICEF Switzerland, who would be talking on preventing infection and improving health in LMICs, lessons learned from water, sanitation, and hygiene programs. And this will be followed by Dr. Benedetta Allegranzi from the World Health Organization in Switzerland. And she'll be talking about WHO IPC strategies to prevent antimicrobial resistance and sepsis. Then we have Dr. Evangelos Giamarellos from the European Sepsis Alliance in Greece, who will give us a talk on the impact of BCG vaccination on COVID-19 and respiratory infections. And we will close this session with Dr. Mervyn from the University of Witwatersrand in Johannesburg, citing sepsis and antimicrobial resistance in ICU patients. So our first speaker is Dr. Benedetta Allegranzi, and I'm going to introduce her briefly. She's a specialist in infectious diseases and tropical medicine, infection prevention and control, and hospital epidemiology, and currently works at the World Health Organization as the coordinator and lead of the IPC Global Unit, including the Clean Care is Safer Care program. Since 2013, Benedetta has gathered the title of Professor of Infectious Diseases in the official Italian professorship list and is an adjunct professor to the Institute of Global Health at the Faculty of Medicine, University of Geneva, Switzerland. She closely collaborates with the team at the IPC and WHO Collaborating Center on Patient Safety, University of Geneva Hospitals, as well as with the Armstrong Institute for Patient Safety and Quality in Johns Hopkins University, Baltimore. She's currently involved in the leadership supervises IPC activities in Sierra Leone and Guinea. She has experience in clinical management of infectious diseases and tropical medicine. She's the author and co-author of more than 150 scientific publications, including articles published in high-profile medical journals, such as The Lancet Infectious Diseases, New England Journal of Medicine, and the WHO Bulletin, and has 6 book chapters. Benedetta, I welcome you to this session. Please take the floor.
Thank you very much, Shade, for the nice introduction, and hello everyone. Good morning, afternoon, evening to everyone, and many thanks to the Global Sepsis Alliance colleagues for co-organizing with WHO this important Congress today. So my role is to talk about the WHO IPC strategy to prevent AMR and sepsis. And in fact, I would like to start to mention some work we have done for the Global Sepsis Report, which was presented this morning and will be launched later today. This work is quite original and innovative because it's the first systematic review on healthcare-associated sepsis, which we have undertaken together with the Robert Koch Institute. And in this systematic review, we have had really many hits, more than 3,000 titles, but eventually we only retrieved and included 51 studies in the review. And out of these, 22 were from low middle income countries. So not a negligible number of studies, but certainly less than other level of income of countries. In the next slide, you can see that healthcare-associated sepsis among all hospital-treated sepsis was 23.6%. So 1 in 4 patients with hospital-treated sepsis had a healthcare-acquired infection and sepsis, therefore. We pooled incidence per 1,000 patients, and this was 15 per 1,000 in adults and almost 10 times higher in neonates, 113. And indeed, we also found out that 57% of all types of healthcare-associated infections were appearing as neonatal healthcare-associated sepsis. This problem was really much more remarkable in intensive care units, where basically sepsis with organ dysfunction was acquired during ICU stay in 24% of cases, and it was of hospital origin almost up to 50% of cases, half of the cases. You can see also on the slide what was the hospital incidence of healthcare-associated sepsis with organ dysfunction per 1,000 patients. And you can see that, of course, this incidence was remarkably higher in ICU than hospital-wide. So what are the consequences of this? I already mentioned that 1 in 4 cases of sepsis were acquired in the hospital among all hospital-treated sepsis, and the mortality, crude mortality of all patients with healthcare or hospital-acquired sepsis was 24.4%. But among ICU-treated patients with sepsis, it was more than 50%, 52.3%. This condition has a high impact, as we all know, on length of stay. So the median length of stay was from 2 to 3 times higher for health care-associated sepsis compared to community-acquired sepsis. And it's interesting also that we tried to identify the sepsis causes from the microbiological point of view, and only 7 studies were able to investigate and report data on this related to healthcare-associated sepsis. And this was due in up to 1/3 of cases to drug-resistant bacteria. So this review has several limitations, in particular heterogeneity and also the difficulties to distinguish healthcare-associated from community sepsis, variable case definitions, low number of studies from low middle-income countries and not covering all regions, so global estimates were really difficult to be made. And also, as I said earlier, no study was measuring attributable mortality. And we had limited data on etiology and AMR. So moving to aspects that are related to infection prevention and control, we know that overall sepsis and infection, both in the community and in healthcare, is highly preventable. We heard many examples of this today. In particular, for healthcare-associated infections, from 35 to 55% are preventable through effective infection control. Neonatal deaths are preventable up to 84%. Maternal infections and related deaths are largely preventable. And now we need to understand how to achieve this. So in the next slide, we can start to mention that WASH, as my colleague later will mention, is really important to prevent infections and sepsis and related AMR. Also, we know that quality of care and infection prevention and control really are critical to prevent AMR, and prevent AMR in the context of outbreaks and outbreaks beyond those caused by antimicrobial resistant microorganisms. We are in the current situation of an important viral outbreak where IPC is at the core of resolving this problem. We also know that effective IPC interventions are cost effective and actually have a cost benefit. So we know from OECD, these are data that we displayed in a AMR advocacy brochure last year, where we really, in a snapshot, we explain that the frequency of AMR infections can be reduced by 2/3, combining IPC, hand hygiene in particular, with antimicrobial stewardship programs. This way, only in Europe, we can prevent 27,000 deaths every year, reducing the health burden of infections leading to sepsis as well by 85%. And we can save €3 per capita in Europe every year by these interventions. However, we have a serious problem. That is lack of IPC and IPC implementation. Here, I'm going to present you some data collected by WHO. In this case, high-level data. We know from the AMR monitoring system that 88% of countries worldwide report to have an IPC program nationally, but only 28% report that they actually have implementation nationwide at healthcare facility level. WHO undertook a more detailed study in 2018, interviewing 88 national IPC leads and gathering really much more detailed data on the fact that, according to these national IPC leads, there are 62% of countries having a program at the national level, but only 26% have a budget dedicated to IPC, and implementation is much lower, ranging from 22 to 67%. And in the graphs, you can appreciate that there is a significant difference between high-income countries and in particular low-income countries in these various variables that I just mentioned. Similarly, 67% of countries have national guidelines, but only 36% of them have a guideline implementation strategy, and only 22% monitor their implementation and compliance. Less than 50% of countries have training for IPC. And again, there are remarkable differences between low middle income countries and high income countries. The last piece of data from our program is a very recent program monitoring survey that we undertook in 2019 on IPC implementation at the facility level at this time. So on average, facilities were actually doing quite well in this sample of more than 5,000 facilities from 112 countries, because on average they were on a level that we call intermediate level of implementation of IPC. But you can see on this slide that there is a remarkable difference between low-income countries, which are actually at a basic level of IPC, and lower and upper middle income countries and high income countries, of course. And in the same survey, there was a dedicated section on hand hygiene, and we can really appreciate the same on the slide that is on the screen now. Only basic level for low-income countries, advanced for high-income countries, and intermediate for low-middle-income countries. In particular, regarding hand hygiene, in the first bar, which is related to facilities availability for hand hygiene, infrastructure, supplies, and so on, you can see that the score is really low for low-income countries, is the brown bar, compared to the others, which means that still there is a long way to go to supply hand hygiene equipment at the point of care in healthcare facilities in low-income countries. And indeed, we know that lack of WASH and IPC services causes a number of deaths every year, which was established by a systematic review, very interesting, published in 2019, related to the fact that 1.6 million deaths are attributable to lack of WASH due to obviously infections, and some of these obviously are sepsis events. And in particular, almost 1 million deaths are due to WASH failures among diarrheal diseases, and we know that diarrhea is the first cause of sepsis, as previously reported by other speakers. Other data by WHO show that we have gaps in WASH, according to a report which is about to be issued again by WHO at the end of this year, again saying that, for instance, 1 in 4 facilities lack basic water, 1 in 10 have no sanitation, and 1 in 3 lack hand hygiene at the point of care. So what to do to prevent sepsis? So 2 years ago, we dedicated the hand hygiene campaign to this. We established that there are 2 levels preventing sepsis in the community and in healthcare, and preventing infection or preventing the evolution of sepsis of infection to sepsis. So preventing infection in the community is highly effective. Improved hand hygiene can cut the risk of diarrhea by at least 40%. WASH improvements can result in a 10% reduction of total burden of disease worldwide. And there are other interventions such as breastfeeding and vaccination, which can prevent sepsis and infectious diseases significantly. In the healthcare facilities, we have already mentioned the effectiveness of IPC programs. And before we talk about this into the details, it's important to mention that once the infection is established, there are several factors that can be stopped or really fine-tuned to prevent the evolution to sepsis. So improved compliance with sepsis performance bundles is associated with 25% risk reductions in sepsis mortality. Hospital and ICU length of stay was decreased 4% for every 10% increase in compliance with resuscitation bundles. And we have already talked about the effectiveness of appropriate antibiotic use, especially in the first hour of sepsis evolution. So the approaches of WHO to prevent infections, in particular in healthcare, are related to the implementation of 8 core components at the facility level and 6 of these at the national level, which are included in these guidelines, where we have many recommendations in this context. Out of this, we identified what are among these core components and indicators IPC minimum requirements, what needs to be in place at the minimum to ensure safety and prevention of the spread of AMR and of epidemics. We also developed many implementation resources that are available and manuals. And also the WASH program has proposed a strategy with 8 steps to make WASH interventions effective, which are being implemented by more than 50 countries with significant progress. Also, WHO and UNICEF launched a new hand hygiene initiative in the context of the current fight against COVID pandemic. And I would like to remind you that implementing IPC at the point of care can only be done by using multimodal interventions in order to be effective. Multimodal means to integrate different approaches, from infrastructure to training to monitoring to communications and engagement and institutional safety climate and improvement of patient safety and quality of care. This is reflected as an important example which is relevant to sepsis in the prevention of bloodstream infections, in particular those due to vascular catheters. On this slide, you can see many studies that implemented multimodal interventions, including bundles and checklists, and demonstrated a clear effectiveness in reducing incidence of bloodstream infections and sepsis. Another important approach to reduce healthcare-associated sepsis is to reduce surgical site infections. 30% of sepsis are of surgical origin. So the strategies to reduce these infections, in particular in C-section, post-C-section infections, is critical, and WHO developed a package to do so with many implementation tools. We also have guidelines in particular to reduce carbapenem-resistant microorganisms, which are the most frequently responsible for sepsis. And again, we have guidelines and implementation manuals. And finally, we have many training packages available on e-learning in particular, like the one that is displayed on the slide, as well as training that is related in particular to COVID-19 recently, but many other aspects of training that you can find on Open WHO. Regarding training, next week we are going to issue a new document which is entitled Core Competencies for IPC Professionals, and I'm glad to announce this now today. And finally, WHO developed a number of resources specific for infection prevention and control of COVID-19, which can be found on our website. With this, I would like to thank once again the organizers, in particular Mervyn, Zik, and Conrad Reinhardt for their support and collaboration with WHO, and my colleagues who are displayed on this slide. Thank you.
Thank you very much, Professor Allegranzi. You have taken us through infection prevention and control and how this links with sepsis and AMR. We have a few comments and a few questions, a few comments and some questions. One of our participants has said that this is very clear, the presentation, but could you talk about a country or hospital example where multimodal approaches were implemented that resulted in a significant increase in hand hygiene and decrease in infections? That's a big one. So, and the second one is about IPC practitioners, which I think you've more or less answered, that the absence of IPC practitioners in many countries, how has this affected the implementation of some of these programs that you've talked about?
Okay, I'll try to give very short answers. So there are many examples of multimodal strategies. Just to cite one systematic review, which is cited in my slides, identified 19 studies that have shown reduction of healthcare-associated infections by implementing a hand hygiene multimodal strategy. We published in the Lancet Infectious Diseases about the implementation of our multimodal strategy for surgical site infection prevention in African countries. There are really many examples, and especially in the core components guidelines, in the chapter related to multimodal strategies, you can find evidence up to date until 2015. We are currently starting the update of this systematic review, which we hope to issue next year. So there are many examples that this works. Regarding IPC professionals, it's really, I'm grateful to hear this question. Our position, supported by many experts, is that yes, we absolutely need specific IPC expertise to really make effective interventions, and also really collaborate and engage with other disciplines to make IPC effective, and also to convince leadership and so on. IPC is a science, is a discipline, and it requires and deserves really a specialty and a specific curriculum, which is available in a low number of countries, we know, and through some international programs. WHO has a web page where all the programs or courses or certificates in IPC are listed, so that people can understand which ones can be used. But of course, it's true that there is a need for curricula that are adapted also to low resource settings and made affordable. And in addition, we need to advocate for career pathways for these professionals, which are absent in many, many countries, including high-income countries. So this is a high priority for WHO. We will work as one organization with our regions and countries to really achieve significant improvements in IPC training and certificates in the next few years. Thank you for the question.
Thank you. As you were talking, quite a lot of other questions have come up, but I'm not sure we still have time. Maybe we'll just take one. Can you talk about how your group is working with other WHO colleagues on addressing sepsis and healthcare-associated infections amongst mothers, newborns, and children? And I think that will be the last question.
Yeah, that will be very fast as well, I hope. So we do. So at WHO, the work on sepsis is the result of a collaboration of more than 10 departments and divisions. And a very good example is the global report we are launching today, where you can find all these departments listed, and also on our web pages you can find the same. For maternal and neonatal, of course, we collaborate very closely, and I have to say that we are currently developing a training package for implementing infection prevention and control and WASH in maternal and neonatal care. So hopefully that will be available next year. So this will be a tangible product of collaboration, but in the Global Sepsis Report, you can find other good examples of this. Thank you for the question as well.
Thank you very much, Professor Allegranzi. And now we will move very quickly to Kellyanne Naylor, who will be talking to us about preventing infection and improving health in low and medium income countries, lessons learned from water sanitation and hygiene programs. Kelly is UNICEF's Associate Director for WASH, and she has over 19 years of experience in the WASH sector, managing urban, peri-urban, and rural water sanitation and hygiene programs in Central Africa, South Asia, Latin America, the Caribbean, and North America. Since joining UNICEF in 2007, she has completed 5 missions in 3 regions. And prior to becoming the Global WASH Chief, Kelly was UNICEF's Regional WASH Advisor for West and Central Africa from 2014 to 2018, providing technical assistance and guidance for WASH programs in 24 countries, including the 2014 West Africa Ebola virus outbreak and Lake Chad Basin crisis. She has completed 2 missions in the DR Congo, where she supported the development and scale-up of the National Healthy Villages and Schools program. She joined the Haiti country office in late 2010 as coordinator of the WASH technical subclusters for the earthquake and cholera response. She has served in Batticaloa and Kilinochchi, Sri Lanka, with responsibility for the coordination of WASH subclusters and implementation of the emergency WASH response to conflict-affected populations. Prior to joining UNICEF, she started a career in Nicaragua And she completed her undergraduate and master's degrees in civil and environmental engineering at Stanford University in Palo Alto, California, with a research focus on modeling human exposure to environmental pollutants. We welcome you, Kelly. Please, you can take the floor.
Thank you very much, Dr. Ogunsola. And it's just such a pleasure to be here. And I sometimes wonder what a civil engineer is doing in these sorts of things, but I think this is exactly where we need to be. And it's just such a pleasure to be here today, to really be joining forces with colleagues like Benedetta to see how we can really bring together the work that we do in water sanitation and hygiene together with the work that health professionals are doing. So thank you very much for inviting myself and UNICEF to participate in this event. So just really, directly following on from Benedetta's presentation, she talked about a joint report that UNICEF and WHO had put out, where we really looked at what is the situation of water sanitation and hygiene in healthcare facilities. I'm not going to go through all the statistics there, but we found overwhelming information that the most basic facilities for water, toilets, ability to manage waste, and the practice of hand hygiene were lacking in significant numbers of healthcare facilities around the world. And this, of course, was coming at a time, I think our very first landscape report prior to this report came out in 2015 when we were working on the Ebola outbreak. And it really highlighted the challenges, particularly in low resource settings, to be able to put in place an effective infection prevention control when you don't have water, when there are not sanitation facilities, when there isn't waste management, and when hand hygiene is not being practiced. So this report that came out in 2019, came out April last year, is going to be updated this year and is really helping us to be able to pinpoint and highlight where the needs are the greatest. This is some other data that has come out in Bangladesh and looks very specifically around the issue of hand hygiene. And this, of course, has been a tremendous focus as one of the transmission pathways for many infections for keeping both patients and health workers safe. So this work, as we gather for this conference today, I think we've all been highlighted in Benedetta's presentation about the children, the mothers, and the patients who's lost their lives due to poor quality care. And we think that water, sanitation, and hygiene can be an important partner in this move on trying to achieve the health objectives. And when we look at the Sustainable Development Goals and the targets, this is really where we see the ability to bring together water, sanitation, and hygiene together with the goals and objectives of the healthcare facilities. So WASH as a critical input to improving infection prevention control and outcomes. I mean, we know many of these different pathways that WASH can contribute to this, whether it's through the risk of the nosocomial diseases caused by human to human and human to surface contacts, whether it's related to quality of care and the dignity of patients to be comfortable and safe in healthcare facilities, as well as protecting women and newborns during childbirth. So this has also been, water sanitation and hygiene has also been identified as a critical preventive measure towards antibiotic resistance, both directly by the transmission of infections, but also reducing the need to overuse antibiotics due to the transmission of infections. So the benefits of WASH are numerous, and they are very much cross-cutting as we try to look at kind of improving overall quality of care in healthcare facilities. But I wanted to focus today really on sharing a few concrete examples from work that we're doing at the country level. So UNICEF is currently working on WASH in healthcare facilities in 82 countries. As many of you probably know, the UN Secretary General issued a call to action on WASH in healthcare facilities as part of his 2018 World Water Day speech, and that has built a lot of momentum and also led to the World Health Assembly resolution that has really kind of given a big push towards the work and WASH in healthcare facilities. And last year, UNICEF reached directly 3,300, over 3,300 facilities with basic WASH services. So this is work that we're doing both in terms of helping countries to improve the enabling environment using the 8 practical steps, which have been published in the report with WHO and UNICEF that went along with the data report, and that now is part of the monitoring framework for the World Health Assembly resolution. And this really looks at how to build stronger health systems to be able to ensure water and sanitation and hygiene. So I want to go now into an example of a program that UNICEF has been working on with the Every Mother, Every Newborn Quality Improvement Standards. And this was implemented in 59 health facilities in 6 districts during the 2-year period from 2016 to 2018. And this was done in Bangladesh, Ghana, and Tanzania. This program really had 3 key components. It looked at improving the situation of infrastructure. And when we talk about infrastructure, we look at maintenance, construction and maintenance of water points, monitoring water quality, construction of toilets, construction of shower areas, putting in place hand washing equipment, waste segregation systems, burial pits for waste, incinerators. So all of these types of equipment or facilities that are required to make the physical environment safe and healthy. The second part of the program really focused on software components, and this looked at hand washing practices, the implementation of waste management protocols, training of staff, management measures like assigning an IPC focal point, developing behavior change communication, and an innovative approach on using a buddy system to monitor hand washing. The third component of this was really looking at a quarterly monitoring approach by independent research institutions to be able to really assess the functionality of the WASH infrastructures, but also the changes in behaviors and how these measures were being put in place. And this provided an opportunity to really see how this kind of integrated approach could be put in place at the facility level. So a few key components came out of this. I think first and foremost, importantly, was that client satisfaction was increased and that use of healthcare facilities improved. I think another finding, and this of course goes to show that it's not just about hardware, but that this approach of having these quarterly visits with supportive supervision and mentorship really helped tackle some of the practical issues at the facilities level and unlock bottlenecks to being able to make sure the proper use and maintenance and management of the facilities. I think these kinds of things also bring up the issue that there are still challenges that practices like hand washing continue to be done on a regular basis. And I think that's also always feedback to us that, we need to continue to refine methods to make sure that we are advancing on those areas. Another example that we wanted to share was an example from Zambia. And Zambia is a country where UNICEF, together with the Ministry of Health, implemented a package of interventions, which included reactivating infection prevention committees, on-site chlorine production and utilization, improved waste management, and promotion of hand washing at soap. Here, the focus was really on behavior change practices, and that interventions were put in place to trigger behavior changes. This could be signals, footsteps, arrows, signs that help remind hand washing at the critical moments. Another component of this was really putting in place high-level advocacy to try to provide more visibility for the link between WASH and IPC interventions. And I think particularly, again, coming back to low-resource settings where water, sanitation, and hygiene basics may not be in place, these are absolutely critical for being able to put in place an effective IPC response. A next example is a link that we've been making between WASH and energy. And I think overall energy being an important input to many different types of improvements for healthcare facilities. It can also provide piped water supply rather than carrying water in buckets from hand pumps, which can also make and encourage infection prevention control measures at the point of care. So this is another way that we're trying to look at linking improvements to facilities with improvements in the quality of care. And then last but not least, I wanted to share an experience from the Ebola response in Uganda. This is, of course, also some examples, from the West Africa Ebola outbreak, where interventions that were made during the public health response to the outbreak have led to lasting improvements in these healthcare facilities in terms of infection prevention control, whether it's on the side of chlorine production or on the side of waste management. I think we have been able to see that there's been positive improvements at the facility level once these types of equipment has been made available during the outbreak. So just coming back to a few key messages, it is very important that programs that are aimed at improving the quality of care to reduce mortality and morbidity should adequately reflect WASH and IPC and health plans and strategies. We still see many health plans that don't have complete data on the availability of water, sanitation, and hygiene facilities at the facility level. So this is absolutely a critical component of both the collection of data, but also making sure that these are part of national strategies and plans, costed, and that the adequate human resources and monitoring are in place to make sure that those investments really achieve the dividends. I think, again, highlighting the issue that it's not just about infrastructure, but really continued need to attention, improve hand washing practices, because this is obviously a critical component both for patient safety, but also for the safety of healthcare workers, and is one of the most effective infection prevention practices that we can all do to improve the conditions of healthcare workers and the quality of care for patients. So thank you very much. And I think it's really happy to be here and to be having this conversation between water, sanitation, and hygiene sector together with our health colleagues on this important issue. Thank you.
Thank you very much, Kellyanne. that was a very interesting talk, and it showed us very clearly the link between WASH and IPC and the difficulties we're going through in making sure countries recognize the importance of taking care of most of them. You do have a few questions, they're not too many. There's a question here that many countries, regions have undertaken wastewater surveillance for COVID-19, e.g. Finland and regions in Australia. And just last week, an epidemic was prevented at the US University of Arizona with surveillance of dormitory waste. Shouldn't the WHO recommend this? CDRAP said good approach to AMR surveillance too. That's one. The other one is is also from the same person. That what of the cube type of approach to contamination in maternity wards? That even isolated tents could cut down on HAI responsible for diseases and death in LMICs. Otherwise, thank you for a good WHO push for WASH. So I don't know if you understand those.
Great. Yeah, thanks so much for those questions. And I think on the wastewater surveillance, so thank you very much. And this has, I think, been an issue of quite a lot of recent debate in the scientific community. I think while it's been identified that there are virus fragments in wastewater, the current understanding that I had, and again, I'm from UNICEF, so I will defer to the WHO colleagues on the latest standards on this. But I did understand that it was yet to show whether or not there could be transmission from wastewater. So while it could be used as a monitoring tool, it wasn't at this stage being seen as a transmission pathway. But I would, and perhaps I can share, there's a link to the latest guidance on water sanitation and hygiene and waste for COVID-19, which is on the WHO website. And I know that it's been updated recently with more latest information on this wastewater question. So I don't in any way want to spread misinformation. So I would suggest to go directly to that latest guidance on this specific issue. Thank you
very much. We have two direct questions. What is the role of governments in all the mess behind lack of WASH in LMICs as donor funds are poured in the name of health? And can you tell us the percentage of health facilities in Bangladesh that lack toilet facilities?
Great. Thank you very much. I think the question on the role of governments is a very important one. And I think what we see in the water and sanitation sector is that it is very multi-sectoral because, on one hand, we have water and sanitation facilities that serve communities, but then we also have the water and sanitation and hygiene practices inside of healthcare facilities and schools. So I think, first and foremost, I think when we see these, the gaps that we have in both the coverage of water and sanitation in communities and the coverage in facilities, I think often there's issues of fragmentation and accountability around how to make sure that we have more integrated approaches towards making sure that there is a continuity of water and sanitation services in household healthcare facilities and schools. So I think first and foremost, it's a question of coordination. I think secondly, it is an issue of data and understanding the problem. And, the very first time that we had data available on the situation of WASH in healthcare facilities for substantive numbers of countries was last year. So this is a problem. Well, I think it's shown up, and for many of us who have been involved in responding to public health outbreaks, whether they're cholera outbreaks, Ebola outbreaks, the current COVID outbreak, you see it happening at the facility level, but you haven't really seen the scale and the scope of the problem. And so these reports that we've been putting out that do have country level data, and coming to the question on Bangladesh, we can share the link to the report, which can give you all the details specifically on Bangladesh. But it's really raised quite a lot of visibility about this challenge. And we're currently in the process of developing an investment case together with UNICEF, WHO, and the World Bank to really look at what the resource needs would be to get water and sanitation facilities up to the standards for all healthcare facilities. So these are some things that are coming soon, but it does really require a systems approach and not just a facilities by facilities. Thank you.
Thank you very much, Kelly. And in the words of one of the participants, who says, "Dear Kelly, thanks a lot for the interesting presentation. IPC WASH is a marriage made from heaven that nobody can separate. So keep working." Thank you very much.
Excellent. Thank you for the marriage proposal. I really appreciate it. It really made my day. Thank you so much.
You're welcome. So we will now go to the next speaker. This is Dr. Evangelos. I hope I'm pronouncing your name well. Giamarellos Boubulis, who's a professor. Thank you. Who is a professor of internal medicine and infectious diseases at the Medical School of the National and Kapodistrian University of Athens since 2018. He was trained in the immunology of infections at the Department of Internal Medicine and Infectious Diseases of Radboud University in the Netherlands. In 2012 and 2013, he served as guest professor of the Department of Critical Care Medicine of Jena University Hospital in Germany. His main research contribution is immunomodulation in sepsis and in autoinflammatory disorders, for which he was awarded the Young Investigator Research Award by the European Society of Clinical Microbiology and Infectious Diseases. He has 379 publications in international peer-reviewed journals with 15,440 citations and an H-index of 64. He has contributed in the development of clarithromycin for immunomodulatory treatment of septic shock, the recognition of hidradenitis suppurativa as an autoinflammatory disorder, and the licensing of adalimumab for treatment of sepsis. He is chairing the Hellenic Sepsis Study Group. He currently serves as the president of the European Shock Society and the chair of the European Sepsis Alliance. Since the start of the COVID pandemic, he was the first to publish the complex immune dysregulation of severe patients, and he is running 4 clinical trials on treatment and vaccination. Welcome.
Thank you very much. Thank you for your presentation and for your kind words. And I would like to introduce today a new window of hope for the prevention of COVID-19 and respiratory infections. And I believe that the importance of our findings that have just 1 week now been published in Cell are very important, taking also into consideration of one highlight that has appeared today, early in the morning, in the internet, about a severe adverse event of a patient being vaccinated by one of the new under development vaccines to prevent COVID-19. After showing you my conflict of interest disclosure, I would like to show you that already from the beginning of the COVID-19 pandemic, there was an idea that BCG can be used in order to prevent COVID-19. And then the question comes, how this is possible? So before jumping into the surprising assumption of many people around the world, how is it possible for BCG that actually the idea is to be used for the prevention of tuberculosis, that this can be used for the prevention of a respiratory viral infection? I would like first to let you know that this concept is being shared by great many people out there, and there are already 11 ongoing randomized clinical trials in order to study the use of BCG vaccine in order to prevent COVID-19. How now is this possible for this to be the situation? Allow me to introduce you now to the concept of trained immunity. What trained immunity means? This means that our innate immune system comes across a vaccine or an antigen that has a low virulence. This develops, but however, not all antigens and not all vaccines are able to develop that. When, at the second step, we come across an infection which is secondary and which is completely different than the previous one, we are able to develop very strong innate immune reactions and responses. That means a response which is coming from our tissue macrophages in order to eliminate and to contain the secondary infection. However, in order for this to be done, the antigen that is used for vaccination should be able to induce metabolic and epigenetic changes that allow this to happen. From October 2017 until August 2020, we ran a randomized clinical trial with the acronym ACTIVATE. The idea of the trial is to vaccinate elderly, that means aged 16 or more, and we randomize them to get single shot of vaccine with placebo or BCG. At the end of March 2020, when 150 of our patients from the total of 188 who were vaccinated have completed 1 year of follow-up in the study, we decided to go for an interim analysis because it was an urgent need to the call of the ongoing 11 trials with BCG about what can be the frame of safety of the BCG vaccine. At that time point, we analyzed for the predefined primary study endpoint, and the predefined primary study endpoint was the time to first new infection. You see the curve of the time to new infection. In blue are the 78 patients allocated to placebo vaccination. In red are the 72 patients allocated to BCG vaccination. The benefit coming from BCG vaccination is evident, and Cox regression analysis showed that the most of the benefit was for patients with a history of coronary heart disease, chronic renal disease, and for patients with chronic obstructive pulmonary disease. And then somebody may ask, well, the title of the slide is the time to first new infection, but which are the infections against which BCG provided most of benefit? This is the meta-analysis of the time of infections within the trial, and you can see that most of benefit is for all respiratory infections and mainly for respiratory infections of probable viral origin. And the question is, what is the mechanism behind the benefit coming from BCG vaccination? In a small subset of patients who were enrolled at baseline and 3 months after vaccination, either with placebo or BCG, we isolated their peripheral mononuclear cells and we stimulated them and we assessed their potential for the production of TNF, IL-1 beta, and IL-10. It is obvious that post-vaccination, these monocytes were far more potent for cytokine production, and this means a better ability to contain the infection. However, it's not only their ability for better cytokine production. It is also their ability because there are epigenetic changes in the genes encoding for pro-inflammatory cytokines. And you see that these changes are far pronounced in the BCG treatment arm compared to the placebo-vaccinated patients. And then somebody may ask, what is the safety profile of BCG vaccination? Much to our surprise, you see that our patients were actually protected. The rate of at least one serious adverse event was 38.5% in the placebo group, and that was reduced to 23.6%. There was a trend for statistical significance, and I want to emphasize here that the infectious diseases necessitating hospitalization or leading to death are subtracted from this table. In other terms, there is an overall benefit coming from BCG vaccination. We are not the only ones who see BCG as a rising hope against COVID-19. There are 3 cohorts of patients, and with them also comparators. Vaccinated, either with BCG or being unvaccinated. They were followed up. Vaccination took place in November and December 2019. That means before the advent of COVID-19. And upon the advent of COVID-19, they were followed up for clinical signs compatible with COVID-19. The length of sickness is the most striking finding of COVID-19, the most persistent. And you see that this went down from 31% of controls to 21% of BCG vaccinated individuals. We are running now in Greece, in 15 study sites, a randomized clinical trial. The acronym now is Activate-2, where male or females aged 50 or more with comorbidities, mainly coronary heart disease, chronic obstructive pulmonary disease, or Johnson's comorbidity index more than 3, negative for immunoglobulins against SARS-CoV-2, and with a skin tuberculin test diameter less than 10 millimeters, they are randomized to placebo or BCG vaccination, and they are followed up for symptoms and for serology compatible with COVID-19. So, an elderly monocyte, once being vaccinated by BCG, becomes healthy again through epigenetic modifications. And this means less viral infection, a decrease of the overall incidence of all respiratory infections without any adverse events. I strongly believe that this is a very important window of hope against the pandemic that we are experiencing nowadays. Thank you very much for this kind invitation. I'm looking forward to any interaction and any discussion.
Thank you very much, Prof, for that interesting presentation. There are a few questions here that I want to bring up. There's a comment here that says there are countries where the BCG vaccination in children is almost 100%, but they're still having a high COVID-19 case and death rate. What is the explanation for that?
So, BCG vaccination that is taking place during early childhood is to protect long-term for tuberculosis. Here, what I'm presenting is a short-term benefit, which lasts for one, probably 2 years, one by definition, probably 2 years as well, against non-specific antigenic epitopes. So, being vaccinated at childhood does not provide any benefit after 20 or 30 years against other respiratory pathogens. If we want to use BCG against COVID-19, the population, even those who have been vaccinated when they were children, they need to be revaccinated.
Okay, a lot of the questions are actually around BCG, and there's one here that says, just want to know, does BCG really prevent tuberculosis, and what age is limited? What is the age limit of the BC vaccines?
There is actually no age limit. And the reason is because you see here how safe this vaccination is. The limitations of vaccinations are coming from a probable risk for coming from vaccination. The only people who should not be vaccinated by BCG are those who are getting anti-TNF, anti-cytokine drugs, and those who have hematologic malignancies. All the other people may be vaccinated.
Okay. One more question from someone who says, could BCG be the reason in Kenya that we have resisted COVID-19 quite a bit? We have had a mild outbreak, which came under control on its own.
There is a recent publication at PNAS, Proceedings of the National Academy of Science of the United States of America, showing that the infection by COVID-19 was much milder among BCG vaccinated countries. So, however, what the authors do not really provide is the time frame between the vaccination, what time in the past and how many years have lapsed since these populations have been vaccinated. However, this really corroborates what is being asked right now.
Okay, thank you. And I think someone has something that's the opposite, and then we'll go on to another case. He says in Pakistan, everyone is BCG vaccinated, but we have a lot of COVID cases.
I told you what is important is not to refer to vaccination once in childhood. If someone has been vaccinated when he was a child and now he's 50 years old, there is protection only against tuberculosis, but not protection against other respiratory pathogens. So if we want to use BCG for protection against COVID-19, population should be revaccinated.
Okay. I think that's now very clear. Thank you very much.
Thank you very much for this invitation.
Thank you. Thank you very much for that interesting, and I think you've set up a lot of questions for people. So now I'm going to invite our last speaker, and that is Dr. Mervyn, who currently presides as a principal specialist at the Charlotte-Megzeki Johannesburg Academic Hospital, Faculty of Health Sciences at the University of the Witwatersrand, Johannesburg, South Africa. He also serves as the clinical head of the Adult Multidisciplinary Intensive Care Unit at Charlotte-Megzeki Johannesburg Academic Hospital. He's a fellow of the Royal College of Physicians in the UK, a fellow of the College of Chest Physicians in the United States, amongst many. He's involved in various aspects of clinical research. He's a hands-on clinician and has participated in more than 950 lectures and presentations. He's a sought-after presenter, both nationally and internationally. He's the past president of the Critical Care Society of Southern Africa and was the secretary for 17 years, and is the current chairperson of the Global Intensive Care Working Group of the European Society of Intensive Care Medicine, and has been integrally involved in their Live Sepsis project. He's also an invited member of the Society of Critical Care Medicine, United States of America, and is currently addressing sepsis in developing countries. In 2018, he was invited to become a panel member of the next International Surviving Sepsis Campaign Guidelines, as well as be a contributor to the new International Mucormycosis Guidelines. He serves as a council member of the recently formed African Sepsis Alliance. He has received numerous awards. I couldn't bring them all up, including the Surgeon General Commendation Award and the Sam Naidu Award for the Best Clinician, which is conferred by the Southern African Society of Thrombosis and Hemostasis. Most recently, he was the first recipient of the Hilda Datno Jacobson Award, which is awarded to the most competent, caring, and capable doctor in the profession, irrespective of field of interest, amongst many others. Additionally, he has a wide array of interests outside of medicine. Mervyn will be presenting to us today, Preventing Sepsis and AMR in ICU Patients. Welcome, Mervyn, and thank you very much for coming.
Thank you very much for that very kind introduction. And gracious thanks to the organizers for the invitation to participate in this wonderful meeting. I'm going to be addressing aspects of antimicrobial resistance and appropriate antimicrobial use in critically ill patients. And in the time frame that we have, really two independent topics, but we're going to try and link them. These are my disclosures, and we're going to address many aspects of antimicrobial care and start off by looking at various elements that are pertinent to antimicrobial resistance. So as has been shared already within the context of this forum, infections and infectious diseases remain a very important and leading cause of morbidity and mortality around the world. And to go back and just put things into a nutshell, approximately 30,000 lives per day are lost around the world related to sepsis. If we look at the intensive care unit, those patients who in fact have an infection have a mortality twofold as high as non-infected patients. And something that I've in fact promulgated for a long, long time now, antimicrobials, if we look at all medications that are prescribed, are the most poorly prescribed. Because of that, we see tons of unnecessary costs, side effects, and importantly, the emergence of resistant microorganisms and the failure to treat infections. Now, we should have taken heed 75 years ago when in 1945, Sir Alexander Fleming, in his Acceptance Nobel Prize lecture, had the following to say: "It's not difficult to make microbes resistant to penicillin by exposing them to concentrations not sufficient to kill them." And really, over the ensuing decades, we haven't taken sufficient heed of that particular comment that was told to us right at the outset. And so certainly in the intensive care world and critically ill patients, we're returning to the pre-antibiotic era with lots of multi and extremely drug-resistant pathogens. This burden of antimicrobial resistance is enormously significant. If we look at just some global statistics, tens of thousands of deaths per year, millions of extra hospital days, and overall societal costs that are actually mind-boggling, that run into millions of dollars and euro. And if we don't get our act together fairly quickly and focus on what really needs to be done, despite everything that is out there, we are going to be facing a massive problem, because it is currently estimated that we may be dealing with up to 10 million cases of antimicrobial resistance by 2050, with the current figure of around about 700,000 cases. And that will mean one person dies every 3 seconds from antimicrobial resistance. To put that into perspective, currently, around about 8.2 million people die from malignancy. So this would exceed those numbers. And this will affect every continent on the globe, with Asia and Africa really bearing the brunt. So what are these problem pathogens? And this was described just over a decade ago as the so-called escape organisms, nice acronym to describe the different pathogens. And very soon thereafter, in fact, the K was replaced with the C to incorporate Clostridium difficile, now Clostridioides difficile, and the E replaced the Enterobacter with Enterobacteriaceae, which in fact have also been renamed and are called Enterobacterales currently. And this further has been reviewed, and in fact it is now suggested when we talk about these problematic pathogens and the escape pathogens, we should talk about escape triple C, with the triple C incorporating C. difficile, Candida, and carbapenem resistant Enterobacteriales, and that last E includes two very, very important groups of pathogens, the ESBL producing pathogens and the carbapenem producing pathogens. So what has happened over the last several years? If we look at what is going on around the globe, if we look at gram-positive pathogens, There's been some change in some areas, escalations of Staph aureus, particularly methicillin resistant, in other areas, in fact, gone down. Enterococcus species gone up, and gram-negatives a huge problem with Enterobacterales, Pseudomonas, Acinetobacter species with very, very significant impact. We look at current resistance rates in major pathogens around the world, and the figures that are represented, in fact, come from a multitude of sources, including the WHO, CDC, the EARSnet, the INEC groups, and the CHINET research survey groups. And we will see that we are dealing with very large percentages of microorganisms that are resistant, the ESBLs, the carbapenem-producing Enterobacteriaceae, and MRSA, and these are really global problems. If we take that map and put it into some form of graphic, we can see E. coli resistant to third-generation cephalosporins and fluoroquinolones in up to 96% of cases that are documented in some regions of the world, and resistance to carbapenems, particularly Klebsiella pneumoniae, very significant, up to 68% in the European region, and then varying rates for MRSA with figures as high as 90% in some areas of the Americas. We focus very dominantly on bacteria, but we shouldn't forget that other pathogens also are evolving and resistance issues are emerging. And fungi, in fact, are one of those groups. And this was, in fact, a commentary that was written and put together. And in fact, I entitled it, "Lest We Forget, Fungi Flourishing and Fatal in Man, and Now the Fear of Resistance." We have emerging Candida species, particularly non-albicans Candida species that are resistant to azoles, and some of them to echinocandins now. And in fact, we have multi-drug resistant Candida species like Candida auris that are emerging. Aspergillus species, similarly with azole resistance, a major concern. And then there are many different infections that in fact make up a very significant proportion of all the infections and potentially sepsis that we see around the globe. Tuberculosis, malaria, HIV, and influenza that we should not forget about when it comes to antimicrobial resistance. So let's go back and focus on the bacteria and on antibiotics. And one of the really pertinent commentaries that has come out in the last decade or so, in fact, came from Johan Neumann in Clinical Infectious Diseases. And I think he was pretty spot on with what he had to say. The major reason that antibiotics are prescribed inappropriately, driving this resistance, is that there's a lack of knowledge about infectious diseases and antimicrobial therapy. And healthcare workers are afraid not to prescribe antibiotics. And so I think if we take a moment to digest that, nothing in life needs to be feared. What needs to happen is that we actually have to understand issues. And in fact, this was a sentiment put forward by Marie Curie, who in fact taught us a lot about imaging. And so when we in fact prescribe antibiotics, it's imperative to have an understanding of the pharmacokinetic and pharmacodynamic principles. That is how the antibiotic gets into the body, and once it's in the body, what its effects are. And if we want to, in fact, prescribe suitably so that we can achieve complete bacterial eradication and limit the risk of resistance, we have to have an understanding of the so-called PK and PD, because that helps us to determine how we can best and optimally prescribe antibiotics. In a nutshell, 3 distinct groups of antibiotics are recognized: time-dependent killers, concentration-dependent killers, and those that have aspects of both. And it's important to go back and do a very brief lesson in pharmacology to understand these elements. Otherwise, it will not be feasible to effectively prescribe antibiotics to adequately deal with infections and limit resistance. So if we have a look at the concentration-dependent killers with this graphic with the vertical axis representing concentration and the horizontal one time, and the MRC shown in the dashed line here, concentration-dependent killers exemplified by the aminoglycosides metronidazole, daptomycin, are other examples. the important issue there is that peak concentration determines killing activity. And the greater the antibiotic concentration you are able to achieve above the MIC, the greater the killing will be. And so it is important, and we now know that we want to achieve values at least 10-fold the MIC if we want to have successful outcomes and limit resistance. For time-dependent antibiotics, exemplified by the beta-lactams and the carbapenems, agents like clindamycin and the older macrolides, time above the MIC. You've got to be above the MIC, and in 2020, we'd like to achieve virtually 100% of time above the MIC, at least 4-fold above the MIC, if we want to have successful outcomes and limit resistance. And for the agents that exemplify elements of both, such as the fluoroquinolones, azithromycin, tigecycline, glycopeptides, and so on, we want to look at the AUC over MIC value, and that value should be 120 or more. And that is this area under the curve divided by the MIC. So that's quite a lot to digest in a small period of time. And let's just look at the elements and some take-home messages. If we're talking about concentration-dependent killers, we want to achieve a peak concentration that is maximal, at least 10-fold above the MIC, and we talk of a peak to MIC ratio. If we're talking time-dependent killers, we want to be above the MIC, at least 4-fold above the MIC, 100% of the time. The older teaching, where we were told that carbapenems 40% of the time, penicillins 50%, and cephalosporin 60 to 70% really no longer holds true. And if we have agents that exemplify elements of both of those issues, we want a value of greater than 120 for efficacy. And so if we use pharmacokinetics and dynamics, we can optimize bacterial killing, we can knock out the bugs, we will limit resistance because dead bugs, in fact, don't mutate. Can't kill the same bug twice. Let's move on to critically ill patients, and they represent a unique population that's very different to the ambulant patients that most antibiotics were registered for. And in fact, this commentary, which was recently published and in 2 pages, really puts together most of what one needs to know in the context of this entire topic, was, I think, very aptly labeled antibiotic administration in the critically ill in need of intensive care. In fact, we need to go back and look at what we in fact are doing so we can optimize things appropriately. And patients who are critically ill have increased volumes of distribution, increased cardiac outputs and hepatic and renal flows, and hence increased clearances. Protein levels are low, and so antibiotics that are highly protein bound become free and are passed out in the urine. And very often these patients land up requiring renal support. And that renal support is not a uniform issue. There are differing clearance rates, so you cannot predict the effects. So if we have a look at this graphic exemplifying sepsis in critically ill patients and focus on the left-hand side of the graphic, if we have septic patients who are critically ill, you have increased cardiac output, leaky capillaries and or altered protein binding. As a consequence, you have increased clearances and volumes of distributions, low plasma concentrations of the antibiotic, and if we do not dose and take this into account correctly, we will in fact confer suboptimal therapy, potential failure of therapy, potential poor outcome, and potential development of resistance. Now, further concepts have come forward in the last couple of years, and one of the very important ones is so-called augmented renal clearance. And in critically ill patients, we now in fact understand that there's enhanced renal elimination of circulating solutes, and that includes antibiotics. And in a subgroup of these individuals, these clearances go to very high levels. The definition is a level greater than 130 moles per minute per 1.73 meters squared. And it is common. It occurs in up to 85% of patients. And again, if we are not cognizant of this, we will get rid of renally eliminated antibiotics, have suboptimal antibiotic concentrations, fail therapy, and in fact drive resistance. We also now know who's at risk for augmented renal clearance, and it's younger people, trauma, post-surgical patients, patients with sepsis, hem-oncology patients, burn patients, pregnant patients, and those who have lower severity scores. And there's now evidence that this lasts for at least up to a week in severely ill patients. So this concept of augmented renal clearance, absolutely paramount to understand how we should in fact be dosing and consider elements when we do dose critically ill patients. And so very frequently one is asked, what are these so-called pharmacokinetic and dynamic issues and differences in critically ill patients got to do with resistance at all? Isn't it a microbial issue altogether? And the answer is absolutely no. The microbes are very important, but dosing has a lot to do with antimicrobial resistance, because low exposure to antibiotics in fact facilitates or enables the development of resistance. There are various ways that we can in fact address it, and in the reference that I alluded to earlier on, we've in fact supplied some ways that we can in fact do that by giving loading doses, dosing more frequently, if one has access to therapeutic drug monitoring, invoking that and considering continuous and extended infusions. So how should we administer antimicrobials and antibiotics in particularly optimally? And I'm going to look at the beta-lactams and carbapenems. And traditionally, the ways that we've administered have been orally or via intermittent injection. And there's been a focus over the last couple of years looking at extended infusions, in other words, over 3 to 4 hours, or continuous infusions over the entire daily interval. And when we talk about extended and continuous infusions, people have often referred to both of those as prolonged infusions. And we should always precede those, in fact, with a bolus dose. Do these make a difference? And there's been a lot of controversy, but the very latest meta-analysis and systematic review has concluded that prolonged infusions are associated with lower all-cause mortality. Is this new data? And in fact, for those who have an interest in this, if you went back close to 70 years ago, Harry Eagle, in fact, described something similar in the New England Journal of Medicine. And I'll just point out the elements that he alluded to. The most rapidly effective form of treatment is one that provides antibiotic continuously in excess of the effective level, so that both the drug and the host defenses are continuously operative. What about duration? And in a nutshell, no one really needs antibiotics for more than 7 days, and perhaps even shorter durations. Anything beyond results in resistance and superinfection and resistant organisms. Of course, in some conditions, more protracted therapy is required: infective endocarditis, deep-seated bone and joint infections, pneumocystis jirovecii, pneumonia, patients who are neutropenic, those who are candidemic, and those who have Staph aureus infections. And so if I had to confer and share with you what, in fact, we should be doing, looking at years of literature and decades of trials in one particular slide: for community-acquired pneumonia, at least 5 days, continue for 72 hours after the patient's afebrile. For HAPS and VAPS, 7 to 8 days, longer for non-fermenting gram-negative bacilli, in other words, Pseudomonas and Acinetobacters, around about 10 days. Bloodstream infections, 5 to 7 days, more than adequate. If it's a Staph aureus, 14 days if uncomplicated, and longer if complicated. For intra-abdominal infections, imperative to have adequate source control, but you only need 4 to 7 days. Excellent study by Sawyer. And for urinary tract infections, 3 to 7 days. And that is across the spectrum from uncomplicated to acute pyelonephritis. Years and years and years of literature in a few minutes. One or more agents, generally monotherapy. Consider dual therapy at the outset in septic shock, where Pseudomonas may be a consideration. You're not aware of your local susceptibilities. For severe community-acquired pneumonia, where one's using beta-lactam and macrolide combinations. For carbapenem-producing Enterobacteriaceae, 2 and sometimes more agents. And for various other conditions, such as infective endocarditis and neutropenia. What are the pitfalls briefly? And it's treatment of non-infectious diseases with antibiotics. Treatment of colonization, because you culture a bug. If the patient doesn't manifest the features of sepsis, they don't need an antibiotic. It's overuse of combination therapy and the use of antibiotic for persistent fevers. Go back and use that wonderful clinical acumen that we all were taught and reassess the patient and its inadequate source control. Look in your surgical patients whether they don't need to go back and have drainage and debris de mar. The solution to the pollution is dilution and pull out foreign bodies and devices that are not necessary, and evaluate your patients on a daily basis. Prophylaxis, all I'm going to say is you need one dose. And so if we look in summary at interventions to address antimicrobial resistance in the ICU, we need to enforce infection control practices, develop antimicrobial stewardship programs, and hand hygiene has been addressed very eloquently earlier on. Look at how we dose antibiotics and review this on a daily basis. And in fact, over the last several years, we've been formulating an issue where in a single template, every single issue that is pertinent to the application, administration, and correct use of antibiotics, and that covers the pillars of antimicrobial stewardship. In other words, appropriate antimicrobial prescription together with infection prevention control practices has been put together. This will be put into some formalized format in a short while, and it's just a couple of Ds, and if you remember just some of them, you will know more about antibiotic therapy and what we should be doing than currently appears to be prevalent out there. Just to give you an example, we've spoken about deliveries, administration. Delay would be timing, getting in early. Devices would be source control. Descriptive diagrams are elements that are very useful where literacy may not be an issue and there's direction for dialysis. So I really think we have a template where in the future we can actually go out and in a pragmatic, practical fashion, in fact, share elements that everyone will know what they need to. So in conclusion, we're really dealing with a massive problem when we talk about antimicrobial resistance. Injudicious antimicrobial use is a massive problem. We need to, in fact, enhance and improve those elements. We're seeing lots of emerging pathogens that are problematic. We do possibly have something that could help with the Ds, and I'd like to advocate all of you to continue with insistence and persistence to fight against resistance. That's just a summary of what we've discussed, and I'd like to finish off this session and perhaps the course of what has been a day for me with some wisdom from a wonderful human being, Nelson Mandela, whom, when I think history is written, will go down perhaps as the greatest statesman that did live. And he had the following to say, and I think we should take cognizance of that. It's in your hands to make a difference. And the rest of the quotation is finished off, to make this world a better place for all. So on that note, and to finish off very briefly with the Ds, I'd like to appeal to all the dedicated delegates, dispensers, doctors, dignitaries, developers, distributors, and dealers, in other words, the pharma industry, to go out and disseminate this information. And humble and gracious thanks for the opportunity to share these elements with you.
Thank you very much, Dr. Mer. That was brilliant. But before I go into questions, the next session is about starting, and if there are people who want to join it, you will have to leave now so that you can join the other one. What I have here are lots of talk on how great this presentation is, but we have a few questions. Yes, this person says, yes, fungi, we need to pay a lot more attention to invasive fungal infections, especially with the increasing reports of resistance. And there's a need to improve diagnostic capacity in LMICs. So how do we increase awareness and diagnostic capabilities? And what have you found in your work? That's the first question. Do you want to answer that, or should I ask you the second one?
No, thank you very, very much. And fungi is something I actually am crazy about, particularly Candida. And I think the diagnostic elements, if you have a look at virtually every every week there's another new editorial, commentary, question, paper out questioning how do we make a diagnosis of invasive candidiasis. And in fact, I don't think it's that difficult. I think it's about a compilation of issues. And that compilation includes good clinical acumen, taking into account the relevant risk factors that are pertinent. It should also, and that is where in low middle income class countries where issues are hugely problematic in terms of diagnostic capabilities in some areas, that goes a long way. The patients who are at greatest risk, who are critically ill, are those that are severely ill, those with invasive devices, those that have gastrointestinal problems, those that are immunocompromised, and those that have had prior antibiotic administration. So in fact, I call those the big five coming from Africa. Those are the big five risk factors. Then we need to, in fact, look at what our best yield is. So even if there isn't fancy laboratory technology available, the amount of blood that is taken, if you suspect that a patient may have an invasive candidal infection, you need to, in an adult patient, take at least 60 ml of blood. And you don't need anaerobic bottles if you want to get your best yield. And I'm sure many of the audience have heard about the missing 50%. Because blood cultures are not a great way. There are various scoring systems that have been advocated in non-neutropenic patients that help one to determine or certainly exclude in the so-called Leon score, which looks at a variety of different, very simple bedside issues, just 4 elements, and you can get a simple score. If it's less than 3, you can virtually exclude invasive candidiasis. And then there are very useful technologies. The beta-D-glucan in the first world, nanotechnology has been utilized, the T2MR, and these, in fact, can tell you, in conjunction with the elements that I've mentioned, give you a high index of suspicion. And in the coming months, there will be a point-of-care beta-D-glucan test, which I think will be useful. And the beta-D-glucan's best issue is its negative predictive value. So if it's negative, you can exclude Candida. And then finally, imaging is also very helpful, particularly in neutropenic patients, immunocompromised patients. Very, very simple ultrasounds that anyone can do. You don't need major training. If you're worried about chronic hepatosplenic candidiasis, which can be a difficult diagnosis, there are pathognomonic issues. So I think a lot can be done, and I think too much has been made of the inability to make a diagnosis, certainly of Candida. I think if we use a compilation of issues, and it's an entity I've spoken about before, demystifying the diagnosis, we can go a long way to addressing that issue. Aspergillus, a little bit more difficult, but there are ways, and risk factors are very relevant there as well.
Thank you very much. You still have a few questions, which I think we will try and answer, if you can, as briefly as possible, otherwise we're not leaving. Acinetobacter bovina and Klebsiella and Enterobacteriaceae in IC is almost a death sentence in LMICs because they show resistance to all antibiotics that we have. How would you suggest treating them?
Thank you. It's an excellent question. I'm the eternal optimist, and I run an intensive care in a low middle income class country. And so when I look at issues, I always try and be pragmatic. It's the one entity where combination therapy is required. So if we're looking at carbapenem producing Enterobacteriaceae, and I'll give you fairly verbatim issues that I think are now widely accepted in terms of what we should be doing. We would use combinations of colistin and a carbapenem, provided the MIC, if it is available, is less than or equal to 8, with or without an aminoglycoside, or tigecycline. We don't really have access to phosphomycin, but that is an option as well. If it is a so-called KPC or OXA48, which we see a lot of in Southern Africa, we would consider as well ceftazidime avibactam if it is available. For the Acinetobacters, what we're currently using there is a combination of colistin and tigecycline, and the dosing is very, very important. You can use carbapenems, aminoglycosides, as well. And again, it's combination therapy. The colistin needs to be dosed correctly because it takes time to get to steady state. So you've got to give an upfront dose of 12 million units, and we follow with 4.5 million units twice daily, or 3 million units 3 times a day. So 12 million units up front, 9 million units to follow with normal renal function. If there's impaired renal function, we dose adjust, and any of the delegates is most welcome to be in touch with me, and I'm very happy to share what we would do in those sort of scenarios. And then for extremely drug-resistant Pseudomonas aeruginosa, which is also an emerging issue, colistin aminoglycosides, carbapenem combinations is generally what we use, and if there is access, ceftolozane, tazobactam, or ceftazidime, abibactam are very useful options, but not if there's a so-called metallo-beta-lactamase producing Pseudomonas. In that setting of the newer agents, the ceftolozane, tazobactam is better pseudomonal activity. So if that is all taken in, I've just effectively given another lecture and put into perspective what I think should be done, pretty much inferencing everything that is currently in the literature.
Thank you very much, Mervyn. There's a specific question that I'd like to ask that we have here. If you had to treat infective endocarditis with dual antibiotics and you don't have a culture, what will be the combination of choice?
So it does depend on the background of the patient. Is this someone directly from the community with previous rheumatic disease and perhaps inappropriate oral hygiene? Is it an older individual who's had lower GIT symptoms because the pathogens are somewhat different? Or is it an intravenous drug abuser? And we see, in fact, in my domain, quite a lot of intravenous drug abuse and Staph aureus and all sorts of pathogens. But as a rule of thumb, a beta-lactam and an aminoglycoside, with the aminoglycoside for 2 weeks, and then we drop that. If you still do not have a pathogen and you are worried about staph, then cloxacillin or cefazolin would be useful entities for individuals who've come from the community. And remember, culture-negative endocarditis, always consider fungi, consider Q fever, and consider the so-called HACEC group of organisms. If you have a laboratory, these are fastidious organisms that require longer durations of plating. Otherwise, you miss them. So hopefully, in a nutshell, that gives you an entity, and then target your therapy against activity markers, cessation of constitutional symptoms, and in general, we're looking at 4 to 6 weeks of therapy. There are definitive indications for surgery as well, which once again, I'd be happy to share if anyone is interested.
Thank you very much, Mervyn. I'm sure if I let, that was a brilliant presentation, and a lot of people, it's all about insightful, amazing, informative, impressive, excellent. And I want to say thank you, because as you said, antibiotics, a lot of doctors have issues with antibiotics, and it's a lot more complex during sepsis, where you're also having leaky arteries and everything that's going wrong is going wrong. And you have to really look at the way the antibiotics work. Thank you very much. So, well, on that note, I'd like to thank this wonderful and very interactive and engaging audience. I also want to thank our panel speakers for giving us so much information, and we're looking forward to getting these on YouTube. And before I leave, I also want to thank those who have made this possible, the people working in the back end. Thank you very much, and have a very fruitful afternoon. There's still more going on in the next session, so please join the next session. Thank you very much. Bye-bye.